So thank you all for coming. This is the first time we're doing an in-person version of any part of this session, which for me is exciting. Zoom fatigue is a thing, so it's nice to not talk into a screen. So this is the second part of 4 for this series. So last time we talked a bit about attachment and how that can be disrupted by kids in the foster care system. And today we're going to be focusing on the mental health piece, and I'll go into a little more detail about what we're going to cover today. Just to go over the schedule, next week, the third session will be another Zoom session. We'll be talking about systems and navigating the child welfare and the mental health system. And then our fourth session is going to be a panel discussion, and that'll be in person again. There's going to be a 6-person panel, including me. And that's going to be general, just question answer. So if there's anything that's coming up from these sessions that you find you want to come back to and ask again, or want to talk in more detail about, think about those, because we're going to give you the opportunity to submit some of those questions ahead of time, and we'll do kind of a more impromptu question and answer piece as well. So just keep that in mind as we go through things. If I don't answer a question in the right, way or in enough detail, we can always come back to it again at this panel discussion. The ground rules are the same as last time. They're going to be a little bit more relevant today because of what we're talking about. So no questions about specific treatment plans or medications regarding a specific child. No specific questions about, game plans from various healthcare providers. My answer is going to be talk to them. Hypotheticals are fine. I thought the questions everybody asked last week fell very nicely within the ground rules. So I appreciate that. So what we're going to talk about today is kind of a continuation of what we talked about last week. We're going to focus on diagnoses and diagnostic criteria of a few mental health problems and disorders that are common in kids and adolescents in the foster system. And we're going to talk about both evidence-based therapies and behavioral approaches and medications. And as you will see as we go through this, the non-medication piece is by far the more important piece of the two, especially in this group of kids. However, medications have become an important secondary part of treatment, and it's useful to have some familiarity with what medicines are used and in what situations and why, because then, as parents or professionals, you have a better sense of what questions to ask. So we're going to be doing some breakout groups again, and so for this, I would say move yourselves, because the chairs roll, which is nice, into groups of 3 or 4, and take a few minutes and talk about these 3 questions. What have been your experiences with the mental health system? What are some of the views that you might have or have seen others have regarding the use of medications in treating mental health disorders? And then what barriers to both treatment, and by that I mean therapy, medications, other services, what barriers have you all encountered when trying to access those treatments or services for kids? Let's start with this group over here. What were some of the main themes that came up regarding those 3 questions?
We're talking about medication mostly, and that it can be beneficial.
In what ways? Like, what are the kinds of experiences that it can be beneficial to kids?
To get them settled down before we go to imminent.
Mm-hmm. Okay. So helping them to settle.
Work with them.
Mm-hmm. Okay. Any other thoughts about the medication piece?
Well, my group, we didn't have any foster kids accepting.
Mm-hmm.
And I've been in foster care for 18 years. I had fostered 26 kids, if not more. But what I see, and I'm lucky in this aspect. I live in rural Boston, and I have a huge piece of land with
Mhm.
woods and creeks and everything. So I'm not so much an advocate of medication.
Mm-hmm.
I'm like, let's go for a walk, you know, go in the woods, ride your bike, that type of stuff,
Mhm.
okay? So that's my take on it. Do I believe in medication? Yeah, if they can't settle themselves down,
Mm-hmm.
but I always try the other half first.
So kind of like there might be a time and place for it,
Right.
but a specific time and place
Right.
for it. Okay, yes.
I don't have any foster kids at the moment, but I used to work in a foster home years and years ago. And I did find that it really depends on the kid.
Mhm.
Certain kids do have certain disorders, anywhere from depression to autism.
Mm-hmm.
And so there are absolutely cases where there is medication necessary to be able to create balance so that child can adjust as best they can.
Mm-hmm.
That would be my thought.
Okay, those are all great points. And when we get into the details of the medications later, we're gonna talk about two different approaches for medications depending on different situations. Did anything come up regarding barriers to treatment or services?
My big one I'm dealing with now is parental consent.
Okay. Mm-hmm.
Yeah.
And that might not be one that people think about right off the bat when you think about barriers to services. Most people, the first thing that might come to mind is access to the services, but you may not be able to access anything if there's not consent from other people, right? You're stuck at the starting line until that happens. There might be other barriers not related to finding the services, but like qualifying for them. What do you have to do to qualify beforehand? What paperwork has to be filled out? What evaluations have to be done? And by what people? So, the mental health system has tried to adapt in different ways, but like most big systems, there are areas where there are backups that there probably shouldn't be. And that can delay treatment. And again, this is kind of a preview to next week when we talk about systems, but understanding like how to navigate that and who can help parents navigate those systems makes a big difference. But when it comes to mental health treatment, there are a lot of barriers. So 2 questions, and then we're going to start talking about some diagnoses a little bit. And we'll just kind of do a show of hands, shout out the answer if you think you know what it is. What percentage of children with an active child welfare case present with a mental health disorder, a diagnosed mental health disorder? Any guesses?
E.
Yeah.
95%. Anybody else? C? Okay. Right in the middle. 80%. So, a lot of kids in the child welfare system cross into both worlds between the foster care system and the mental health system. And services for both are important. So the next question, a history of maltreatment and placement in foster care increases a child's risk of a mental health disorder by how much?
Gotta be E.
Yeah. Gotta be.
So it's not quite 10 times likely, but it's still a lot. And it varies, different disorders are more likely than others. For example, post-traumatic stress disorder or an attachment disorder, there's a 5 times higher risk, whereas depression is a 2 times higher risk. It depends on the disorder, but the point is they are much more likely to struggle with mental health problems in addition to whatever is going on with their life changes. Yes?
Kind of regarding both, but more the last question. What's the chicken and what's the egg, do you think? Is it that children with mental health issues are more likely to need foster parents, or the reverse?
Anyone else have a thought before I answer that? Because it's a great question.
You said the first question was diagnosed mental health disorders.
Mm-hmm.
Already diagnosed.
Mm-hmm. So it is a true chicken and the egg question, because to answer that, we'd be going back and looking at, what percentage of parents of kids who go into the foster system might also have a mental health problem. And then you might have to keep going the generation after that, and after that, and after that. So if families aren't able to get supports or treatment, the cycle plays out over and over again. And it might be nearly impossible to find the initial point where something happened. Now, sometimes that's not the case. Sometimes somebody goes into, foster care, and part of it was because they had a traumatic incident before and they ended up developing post-traumatic stress disorder from that, and it's a little bit easier to see where that came from. But for many of these kids and families, it's a lot harder because there can be threads that go back generations into the family, and sometimes, as some of you may know, we don't always have the most up-to-date information on the family or the previous living situation that these kids came from. So we don't always have a great answer, which makes treatment harder. It doesn't make it impossible, but it makes it harder. Any other questions about these two kind of polls before we move on? Okay, so we're going to be talking about 4 groups of disorders, and then the 5th one is not a disorder, but it's an issue that comes up in a lot of situations with kids in child welfare. So we're going to talk about attachment disorders, we're going to talk about PTSD, depressive disorders, anxiety disorders, and then aggression. Before we go into specifics though, I think it's important to just talk a little bit about the general approach to kids who end up in both of these worlds, the foster care world and the mental health world. And the main point is, medicines may be part of it, but if you're not doing, or if that child's not receiving non-medication based therapies and supports, we're only going to get so far. And that looks like a lot of different things. Now, one thing that can sometimes be a bit challenging is that when, say, a child and a family come into treatment, there's going to be a certain amount of treatment where the child is not the focus. And sometimes they may not be the focus at all. The adults, the environment, the school, something else, many other factors might be the focal point. And I think it's important to know that going in, because, I will say, as a parent myself, if I walked into a session and somebody came in and started challenging my parenting style without warning, I'd probably get a bit defensive. Somebody wanted to talk about the meltdown my 2-year-old had last night trying to go to bed, and then the one that happened 5 hours ago when it was nap time, and it took 3 adults to get her to settle down. But, so it's natural to feel defensive, but this is not coming from a place of pointing fingers. It's because everybody around the child is such an important part of treatment. And, it's also kind of an unwritten rule that there's going to be things that the child has to work on themselves. That's kind of an unspoken, assumed rule. And sometimes it's not easily recognized by everybody else that everybody else is going to have to do some things too. So we'll oftentimes ask for more concrete changes from the adults than the child. So what we're going to do is, with each of these disorders, I'm going to show a movie clip to give you all a sense of just like how this is portrayed to the general public. Now, I will say this first clip has some strong language in it, but this is a clip from the movie Good Will Hunting. And there's not a lot of great clips on attachment disorders because I think people struggle to understand what that looks like.
What is it? This is your file. Send it back to the judge for evaluation.
You're not gonna fail me, are you?
What's it say? Read.
Why? Have you had any experience with that?
20 years of counseling.
I've seen some pretty awful shit. Have you had any experience with that? from somebody. So I'd provoke him so he wouldn't go after my mother and little brother. Interesting nights for when he wore his rings. He used to just put a wrench, a stick, and a belt on the table and just say choose.
I gotta go with the belt there, Vanna.
I used to go with the wrench.
What a wrench.
Just fuck him. That's why. Your foster father.
Yeah.
So, what is it like? Will has an attachment disorder? Is it all that stuff? Favorite behavior? Is that why I broke up with Skylar?
I didn't know you did. Wanna talk about it?
No.
You will? I don't know a lot. You see this? All this shit. It's not your fault. Look at me, son. It's not your fault. It's not your fault.
I know.
No. It's not your fault.
I know.
It's not your fault. Alright? It's not your fault. It's not your fault. Don't fuck with me. It's not your fault. Don't fuck with me, alright? Don't fuck with me, Sean. Not you. It's not your fault. Oh my god! Oh my god, I'm so
All right, so attachment disorders are one of the areas that underwent a relatively big revision when the DSM brought out its 5th version, which is kind of like the manual of psychiatric disorders. Up until then, attachment disorders had basically fallen under the umbrella of what's called reactive attachment disorder. And essentially, you need the predisposing factor of a history of a child not getting their emotional needs from caregivers, or because of their life story, there wasn't enough time for them to develop an attachment with a caregiver. And what you see is typically what we call emotionally withdrawn behavior. So they shrink away from support, they don't seek comfort, they keep to themselves, but these kids are still experiencing huge amounts of emotion, and then it will break through at different points. So you get emotions that just aren't matching up with the situation. You get extreme anger and irritability from a minor stressor. You might get fear or worry or panic when interacting with caregivers or other adults. But what we have noticed over time of being able to watch and observe kids that are in the foster care system is there's another group of kids that show pretty much the exact opposite behavior, but it's coming from the exact same space. So in this new DSM, they added a second disorder name called disinhibited social engagement disorder. And you'll see the first part looks exactly the same as reactive attachment disorder. It's the same predisposing situation. But instead of shrinking from support, these kids don't care where they get it from, and they'll seek it from anybody, including perfect strangers. So these are kids that'll just walk up to a perfect stranger and strike up a conversation as if they've been best buddies for 10 years. And they're not hesitant to like go off with these people without like a second thought about like whether it's a good idea or not. They don't respond like if their caregivers are trying to call them back. They'll just kind of float around and talk with whoever's there, interact with whoever's there. And in both cases, the factor behind it is that child did not develop a secure attachment, and in the case of reactive attachment, is essentially terrified of the emotions that would come with trying to form one. And for disinhibited social engagement disorder, the desperation to find one just leads to them interacting with everybody. So it can get very confusing because, as we're going to talk about, the treatment is the same, with some exceptions about kind of how we set up the environment. But the idea is we're trying to strengthen the attachment. Now, as we talked about last week, that attachment can be with lots of different people potentially. It doesn't have to be a child's biological parents. It doesn't have to be a child's foster or adoptive parents necessarily. It can be any person who can function as a stable emotional source for them, a caregiver. Now, there are no FDA-approved medications to treat attachment disorders. So, but you will still see that a lot of these kids end up on medicines for one reason or another. And when we talk about the medicines in more detail, we're going to talk about something called a target symptom approach, which is the umbrella that pretty much all of these kids fall under, because there is no medicine to treat attachment disorders themselves. So we use behavior interventions and therapy to try to strengthen that attachment. So this slide shows a few general points to keep in mind. They're not specific, they're just, it's kind of like the pillars of improving attachment. And they're, on some level, really basic things, but also they can be really hard things. So the first one is consistency. So we will often talk with caregivers about making sure that a child's routine, as much as possible, looks the same every day. But it's not just the routine. It's about the caregiver's response to the child. So if you recall us, when we talked about secure attachments, one of the things that was important was that caregivers emotionally respond in a consistent way to the child. And that's super important here. It's not just about making sure they wake up at the same time every day and that there's meals at the same time, although that's important too, but it's also responding to them the same way. So the child learns to predict what all the adults are going to do when they do something. The next thing is empathy. And this is the idea of trying, even though it's impossible to do sometimes, just trying to understand, like, all right, why might this child be acting this way in this situation? Because I'm having trouble understanding it. And having a sense, and that's where like having a sense of their backstory really is important, as well as kind of keeping a pulse on the other areas of their life, school, friends, community, activities, things like that. The next one is boundaries. And this is both physical kind of boundaries and emotional boundaries. Oftentimes, kids with attachment disorders do not have good boundaries. They don't necessarily, may not even know what a boundary is because they never experienced that in their previous homes or placements. So it's important for the environment they're in to establish those boundaries, and that helps the child learn how to establish their own boundaries. And then the final thing is being available. And that doesn't necessarily mean doing anything in particular. That might just mean just sitting there and letting the child vent for 10 minutes about something. But for kids to feel like they can trust somebody, they have to trust that that person will be there when it is needed. And if that's not consistent, then they're going to continue to struggle developing that bond with whoever the caregiver is. Now, thinking about some specific types of things, this is not the list goes beyond this. But the idea is to follow those 4 main points. One thing I will talk a little bit more is the idea of one-on-one quality time. Has anyone heard of that phrase before? Okay, because that's huge. And that's, again, that's not necessarily anybody doing anything, because usually what we'll say is you let the child tell you what you're going to do for that period. It also doesn't have to be that long either. It can be as little as 15 minutes. But the idea is it's scheduled, it's predictable, and that doesn't change regardless of what's going on with the child. So we will talk about pretty much never using that as a consequence, because that predictability is so important. The consequences can come elsewhere, and that's where like the boundaries can get challenging, because it can be hard to like set consequences for a child you know is emotionally fragile, but at the same time we need consequences to help them understand boundaries and the predictability of the world around them. Now there are also a number of structured programs that have been developed over the years to work with strengthening attachment, and different places have different access to them. One type of program that's available in Western New York is something called Parent-Child Interaction Therapy, or PCIT. Excuse me, and there's a couple of different places that do it. I believe Best Self has a program, and the UB Early Childhood Center has a program too. But all of these structured programs in different ways are trying to emphasize strengthening the attachment between a child and a caregiver. So the therapy often involves that relationship together. And in different ways, there can be some coaching that's involved for both the child and or the caregiver. There may be some programs do kind of structured videos that folks watch. Parent-child interaction therapy often involves the child and the caregiver kind of in a room interacting together, and the parent or the caregiver has an earpiece, and the therapist is observing and kind of giving suggestions to the caregiver about what to do in different situations as the child and the caregiver interact. Yes?
I don't know, this might be a sidebar, but at what point do the parents, I know they play a lot, if the ultimate goal is to give the kids back to the parents, that's the ultimate goal. But at what point do the parents, how long do they engage in these therapies? I mean, is there any people out there that, like, okay, 4 months down the line, do they revisit these parents and these kids that were in foster care? Is there any evaluation going on there? Is it just dry and cut when they leave the foster parents that, you know?
So it depends on the program. Some of these programs have very concrete, like it's 10 sessions, this is what you do in each session, and then at the end of the 10 sessions, you're done. Some of these things, some programs like PCIT is a little bit more flexible. Usually, oftentimes you'll see folks in treatment for 6 months or so or longer. And then the treatment teams will be, reassessing as they go along. There's not a specific endpoint to them. I think the point to your question is there's not a specific evaluation process in place that happens at that point.
Do the courts order these?
Sometimes. They might not order something specific, but they'll say they might say the child and the biological parents or whoever, other caregivers are mandated to do some kind of therapy, and then it's up to the kind of coordination supports to help figure out where that's going to be. Yes?
It sounds like this is just for small children.
So most of these programs are designed for small children.
So what's available for young, middle-aged kids or
Mhm.
early teens?
Mm-hmm. So one example is something called the Incredible Years program, and it's kind of an internet-based program there's a book for it, and then there's different services you can do online. That targets both younger children and kind of adolescents. Another space where they can get treatment is through wraparound services, which is not a foster care-based service, but can oftentimes incorporate some attachment-based strategies. Wraparound services we'll talk about a little bit more next week. It's an intensive outpatient mental health service that kind of brings a bunch of therapy services out to the home for a 6-month period or so. You can get, there can sometimes be attachment-based processes through more so a combination of a child seeing a therapist and maybe having a mentorship program involved too, because that mentor may also be involved with the parents. So there aren't as many services like that for older kids, and that goes back to what we talked about yesterday. The older a child is, the harder it is to reestablish attachment because they're farther away from that critical development period. So these programs that have shown good evidence naturally tend to veer towards the younger kids because it's easier for them to form secure attachments.
So you do get somewhat of an older child past a certain age, and the focus is really not the same, and they weren't caught early enough. What does that present like?
So that can present in a bunch of different ways. As like we talked about last week with that kind of cycle that can happen as kids go through multiple placements, they can come in with a hesitancy to engage in any kind of attachment-based treatment because it opens them up to emotional vulnerability. So it can be hard to even get these kids to start participating in therapy. And therapy, and we'll talk about this more when we talk about PTSD, therapy in the beginning isn't about actually doing any therapy, it's about making sure the kid is in a place to do therapy. And that can take a while. So with these older kids and adolescents, you sometimes have to take that approach and just get them comfortable enough with their own emotions to be able to do attachment-based or trauma therapy or whatever approach is deemed appropriate in that case. Yes?
I have to say though, every one of those things you apply to your teenager or to your preteens. Does it take more time? Absolutely, each one of those takes more time. But those specific interactions, it's a lot more on the foster parent to engage in those. But once you do engage, even if you do they react to half of those. You got that bond. And the other things seem to come naturally.
The biggest part about attachment-based therapy is not really a specific therapy. It's about following those just general points and being available to the child, because that's what gives the space for them to develop the attachment that they need. And it might not happen in the same developmental way that it should have when they were a baby, and it may look atypical at times in some ways, but it can still happen. And I will often tell parents that are involved in this type of work, the most important thing is just that you're doing it. Because that is setting the precedent that the caregiver is not going anywhere. And that's that first piece. That's that first rule for a child, is like understanding I'm safe because this person doesn't go anywhere and protects me. There's a lot of different, you'll see a lot of different specific things you can do, but it really does come back to these just key general concepts. But that's what makes it hard, because they're very general concepts. They can look like so many different things.
So can I just interrupt for 1 second?
Sure.
Or interject, I should say. We talked about Incredible Years, EPIC, which is Every Person Who Influences Children, is in this building, on this floor, and they do Incredible Years. So if anybody had interest in that, they could reach out to Christy or myself, we can get you the information. And we at Mental Health Advocates are part of the wraparound program through Erie County, and we provide family peer advocacy and youth peer advocacy. So if anybody wanted more information, we're part of a big team that goes in and wraps around the family, the services. So if anybody was interested in any of that information, you could just reach out to me.
And People Inc. does Incredible Years for families with kids with developmental disabilities. I went through that myself with my daughter when she was maybe 8 years old, 8 or 9 years old, but they do it through the preteen years.
It's been adapted by a lot of different programs in a lot of different ways, which is why it's a useful program. So we're going to talk next about PTSD. Now this clip doesn't have any strong language, but there's a jarring point in it. I just want to kind of prepare everybody because there's a point that's like kind of jarring. This is from the movie The Hunger Games, by the way.
It's okay, safe, safe. It's okay, you're here with me. You're with me.
Okay. So, does anyone know what that was an example of? Yes. Yeah. You'd have to have seen the movies to understand that. But in the previous movie, she shot another child with an arrow. So when she went to go hunt the turkey, which was a hobby of hers, flashback to that moment and was totally immersed in it. So PTSD often overlaps with kids in the foster care system because they've either witnessed or been victims of a traumatic event. Now PTSD has also evolved a little bit under the DSM criteria, but not to an extreme extent. So there have always been 3 particular categories of symptoms that are part of PTSD, and that's the intrusive symptoms, which is what flashbacks fall under, and it's just these intrusive, unwanted memories or sensations related to the trauma. And then with that come avoidance symptoms. So the child does whatever they can to try to avoid the intrusive symptoms coming back. So they may avoid going to a certain place. They may avoid, smell it. Might try to avoid a smell or a taste or a certain type of clothing that might bring those memories back. And then there's changes in arousal level. And this in part is because their stress response system has been damaged. So these kids will look irritable, they'll be hypervigilant, they'll try to have eyes in the back of their heads, they jump really easily at noises or when they're touched. What has been added to the diagnostic criteria is something called negative cognitions. And that's more about what happens to a child's thought process after a traumatic event. They develop this overly generalized negative view of the world or themselves. And there can be some symptoms there that look like depression, but it's coming from the trauma. The last thing I put at the bottom, we're going to talk about next, and that's something called dissociation. Has anybody ever heard of that term? Yeah. Okay. Does anybody know somebody who's experienced dissociation? The trick question, the answer is yes, because we all have actually experienced dissociation in one way or another. But it's the idea that the mind temporarily becomes disconnected from reality. Now, these examples are things that almost every human being has experienced at some point. Deja vu is a form of dissociation. When you're driving down the highway and you suddenly are wondering how I got from the 290 to the end of the 33 in like no time, and you don't remember what happened, that's dissociation. But for kids with PTSD, it is way more intense and intrusive to them. And flashbacks fall under that umbrella. But these are some of the examples of things that kids will say, or adults will say, that they experience in relation to trauma, where their mind becomes disconnected. And it's a really uncomfortable feeling. And when we talk about medications, this is one thing that we look at to try to help kids with, are these dissociative symptoms. And I say that again because, again, there's no FDA-approved medicine for PTSD in kids. It's confusing because there are FDA-approved medications for PTSD in adults. So sertraline and paroxetine, which are SSRIs, are FDA-approved to treat PTSD in adults. But when they did the same studies in kids, they didn't get the same results. So again, that phrase target symptom approach comes up. Just keep that in mind because we're getting to the point where we're going to talk about what that means. So as I hinted at before, the first goal of treatment is not necessarily jumping into some kind of therapy with the child, because if you do that too soon, you can re-traumatize them, and then you're set back even further. Now, that can be challenging because kids have to go at their own pace until they're ready to do trauma therapy, which we'll talk about in a minute. Because that's the ultimate treatment to help them process what happened. But they can't do it until they're able emotionally to withstand the intensity of the emotions related to it and be able to like sit through dissociation, because that often happens when they're processing their trauma. So we try to help the child reestablish a sense of safety and trust before we do any kind of trauma therapy. And that's where kind of more work might be given to other adults, and there's emphasis placed on like what supports the child has, what changes are there at school to give them more support, things like that. Now there are a couple of different evidence-based therapy approaches that we use for kids with PTSD. The most common is something called trauma-focused cognitive behavior therapy. Cognitive behavior therapy is the mainstay therapy umbrella for kids. So it's used in a lot of different ways. Another one that's not on this slide but is gaining more popularity is something called EMDR. Anyone heard of that before? Okay. It stands for eye movement desensitization reprocessing. It's basically trauma processing, but you have the kids doing things with their eyes to kind of help. It's a grounding exercise within itself. Now, therapists have to be certified to do that, so it's always a good question to ask if you're looking for an EMDR therapist, if the therapist your child's seeing is certified to do it, because some are and some aren't. So the next thing we're going to talk about are depressive disorders, and this is a clip from the movie Inside Out, which as a psychiatrist, I'm biased, and it's one of my favorite movies because it's all about feelings.
Wait, stop! I want to get off! All right, thank you. We will. Her teacher hasn't even seen Riley all day. What was she wearing last year? You remember what... Riley! Oh, we were worried sick. Where have you been? It's so late.
You know what? I miss Minnesota too. I miss the woods and the trees.
In the backyard where you used to play.
The spring lake. Yeah, it was good.
Now, just as a side note, I would not actually diagnose Riley with depression because there's a particularly valid reason for what if you watch the movie, she's experiencing a lot of stress at the same time, but that clip kind of encompasses, and the movie encompasses a lot of different ways that depression can look different in kids than adults. So the criteria for kids and adults are the same when it comes to what leads to a major depressive episode. But with kids and teenagers, they often don't look sad, like can't get out of bed, don't want to do anything. They instead look irritable, or their mood is reactive. It bounces all over the place. And that can make it a little hard to diagnose at times, because you might see some of these other things, difficulty concentrating, changes in sleep and whatnot, but their mood just doesn't look sad. And it's hard to recognize that, well, this might actually be depression. Now, therapy is still a first-line approach, but this is actually a situation where we have FDA-approved medications to treat depression in kids. There's two of them. One is Prozac, which is FDA-approved down to age 8, and the other one is Lexapro, which is FDA-approved down to age 12. We still don't usually jump right into medication, especially if the symptoms are mild. We'll usually look at, environmental changes or therapy first. And if we are getting to the point where medication is needed, we usually want to combine that with therapy. There is ample evidence that shows therapy and medicine together work better than either one by itself. And as I mentioned before, cognitive behavior therapy is the approach that we take the most with kids. Anyone seen this before? So this is cognitive behavior therapy summarized in one picture, but it's used in tons of different ways. So, but the idea that, our behavior influences our thoughts and feelings and vice versa is important, because with kids, behavior, well, with anybody, this is true, but it's especially important with kids. Behavior is the part where we have the most voluntary control. So the therapies focus on behaviors in a lot of different ways, because then that feeds back into changing thoughts and feelings. But it can look like a ton of different ways. So the last thing we're going to talk about is anxiety, and this is a clip from Finding Nemo. And I would focus on the dad in this clip.
Where's day school? Wake up, wake up. Come on, where's day school?
No, I don't want to go to school. 5 more minutes.
Not you, Dad, me.
Okay.
Get up,
Huh?
get up. Time for school, time for school, time for school, time for school.
All right, I'm up.
Boy, boy, whoa.
Nemo!
Where's day school?
Nemo, don't move! Don't move! You'll never get out of there yourself. I'll do it. All right, where's the break? You feel a break? Sometimes you can't tell because fluid is rushing to the area. Now, any rushing fluids, are you woozy? How many stripes do I have?
I'm fine.
Answer the stripe question.
3.
No! See, something's wrong with you. I have 1, 2, 3. That's all I have. Oh, you're okay. How's the lucky fin?
Lucky.
Let's see. Are you sure you want to go to school this year? Because there's no problem if you don't. You can wait 5 or 6 years.
Come on, Dad. It's time for school.
Forgot to brush.
Oh.
Do you want this anemone to sting you?
Yes.
Brush.
Okay, I'm done.
Up, you missed a spot.
Where?
There. Right there. All right, we're excited. First day of school, here we go. We're ready to learn, to get some knowledge. Now, what's the one thing we have to remember about the ocean?
It's not safe.
That's my boy. So, first we check to see that the coast is clear. We go out and back in. And then we go out and back in. One more time, out and back in. And sometimes, if you want to do it 4 times.
Dad.
All right, come on, boy.
Dad, maybe while I'm at school?
Okay. So this is a list of some of the different anxiety disorders that you'll see kids with in different ways. The treatments, the therapy treatments vary, even though they're all different kinds of cognitive behavior therapy. The medication piece is pretty similar. And again, this is a situation where therapy is a first-line treatment, but we also have FDA-approved medicines. This time we have 4, depending on the age. And the same thought process about when we use medicines is true with anxiety as it was with depression. Mild symptoms, you don't usually need to start medication. Moderate to severe symptoms, you want to have the conversation, but also in the context of therapy happening too. So the last thing I said we were going to talk about is aggression. And that can show up with just about any psychiatric disorder. So aggression is not a disorder. It's a symptom of a disorder, or it's a behavior. That's how we look at it. Because literally just about any psychiatric diagnosis can come with aggression in different ways, including all of the ones we just talked about. You can see aggression for different reasons for kids struggling with attachment problems, trauma, anxiety, or depression. But this is a situation where, and this has a lot of different viewpoints, this is a situation where medication comes up, and for understandable reasons, there's a wide gamut of feelings about it, including with psychiatrists. So in the interest of time, we're going to not do a formal breakout group, but I would like you guys to just quickly take a look at those questions and just shout out any thoughts that you have related to them. So in case you can't read it, the questions are: what have been your experiences with psychiatric medications? How have they been beneficial and challenging? And I think the most important part, what did you wish you knew about them before they were a part of treatment for a child?
No experience.
I think one of the challenges and the experiences that can come with the psychiatric medications is really finding the right medicine.
Mm-hmm.
A lot of times, you know, the kids that I get to work with, they've been on 2 or 3 because they're trying to find the right medication, get it to the right dose, and sometimes there's more than one, so it's hard to get that balanced as well.
Mm-hmm. There's the term trial and error comes up a lot when we talk about psychiatric medications, especially when there's not a diagnostic algorithm, which is the case for any kid with an attachment disorder and any kid with PTSD.
I can imagine the difficulties. I was 40 when my brain said, how would you like to have epilepsy out of nowhere? And the first medication that I was put on made me hallucinate that I was seeing bananas around the house.
Mm-hmm.
I was yelling at my wife, why are there bananas on the bed? I didn't know there weren't bananas.
There
And
were no
eventually,
bananas.
there were no bananas anyway.
Thank you for clarifying that.
Just so we all know, right?
Yeah, we keep our bananas on the futon.
Good to know. Good to know where they are.
But yeah, it took a couple of different combinations
Mhm.
of medicines to get it under control. It took a while. I can't imagine it with a 2-year-old.
The other
Mhm.
thing is too, I would imagine with little kids, they don't know that their reactions to medicine are not correct, and they may not be able to communicate that.
That's true. I will say, for the vast majority of situations, if the kid is under the age of like 5 or 6, we're not going to talk about medicines, unless it's an extreme circumstance. One exception is there is one medication for ADHD that is approved down to age 3, and that is Adderall. But even then, well, I'll be frank, I've never put a 3-year-old on Adderall. So, you know, once you get to like 5 or 6, most psychiatrists will start having the conversation and think about whether it's necessary or not. Yes?
My experience with teenagers have been that they don't take.
Ah,
They don't
so
take
do they
it.
take the medicine consistently? That is a great point. And the answer oftentimes is no. And that might be because they're not motivated, it might be because they don't understand, it might be because they don't like the way it feels. There's a lot of different reasons why that comes up, but it is really important to know whether or not the child is taking the medicines consistently. That sometimes leads to a bunch of trials that aren't really trials because it's not being taken the way it's supposed to.
We watch our daughter take it
Mhm.
every day, like she takes it, but she's been doing it since she was 8 or 9, and she knows, and she's 15 now.
But it's hard when you're in foster care, you're the foster parent,
Right.
because you can't make them take it.
You can't.
You just tell the doctor but, you know, then again, and try to explain to the teenager that doesn't take it that, you know, he's gonna end up having, or they, him, her, whatever, that it's to their benefit, really, but then, you know, then that's where you come into where they have to go, you know, to the psych ward and get reevaluated, and
Mhm.
it's just
It's a difficult challenge, yes.
At what age do we involve the child in this process? I mean, this is what this is called, this is where
Mhm.
they're having it, this is what we're likely to see with it.
So if,
Like,
I mean, I think most psychiatrists would say if the child's able to understand what's going on, we want them involved in this discussion. Now, the conversation is a bit different with a 6-year-old versus a 16-year-old.
sure.
But the child's the one taking the medicine, and the child's the one who's gonna feel whatever helps or doesn't help it.
Yeah.
Like, you're not, so you want to try to have them be part of the conversation if you can. And it, you know, their level of involvement is gonna be different depending on their age and where they're at developmentally.
Yeah.
But yes, it is important that if you can, that they're part of the conversation. That helps with them being comfortable taking it if they feel like they're part of the conversation, and or get to be part of the decision-making process. So there are 2 main medicine approaches that happen in psychiatry. One is the diagnostic algorithm, where there's enough evidence that says if a child meets this diagnosis, this is the medicine you should use first, and then this one, and then this one. And there's some cases where that's what happens. ADHD, anxiety, and depression all have algorithms that have been developed. But without that, then we talk about the target symptom approach, which is we're not using medicines to address a diagnosis, we're using medications to address a symptom, which inherently is not the ideal strategy, but because we don't have the best sense of why psychiatric medicines do what they do, that's kind of where we're stuck with. Now, I will say there is a lot of research going on with how psychiatric medications affect kids' brains, and we're learning a ton of information. But it's not at the point where we can apply it yet. So that makes it challenging, right? So these are the main classes of medicines that we're going to go over relatively briefly, and then I'll kind of open it up for more directed questions for any of them. But these are the target symptoms that these medicines can help with, you know, if it's not a diagnostic algorithm. Now, some of these medications are part of diagnostic algorithms, and it's a lot simpler then. So the SSRIs are one of the mainstays of psychiatric treatment. We've had them around since the 50s. And so we've had time to study them, and we have some FDA approvals for them. They are the number one, yes?
What does SSRI stand for?
That stands for Selective Serotonin Reuptake Inhibitor. So what they do is, essentially, to break it down, these medicines make more serotonin available for the brain to use. They don't create serotonin, but they prevent it from it being taken in by the cells. And when they're kind of floating out in between cells, that's where they can have impacts on emotions. Now, we used to think it was just all about serotonin, but we know better now. It's more complicated than that. But there's still a lot of evidence that these medicines are helpful. So they are the maintenance treatment that we use for depression and anxiety, and for adults, they're used for PTSD. We use them a lot too because they're safe. Their side effects are not serious, most of them, and most kids tolerate them just fine. Now you'll see there's a couple of rare and serious ones that come up, and that first one comes up a lot when we discuss medications because there's a warning on the box of any SSRI that you get. But I will say that the risk of the increased suicidal thoughts is rare. It's about 3 to 4%. And they found that when they did studies, kids that took placebos, the rate was about 1 to 2%. So statistically, it doubles your risk, but we're talking about low numbers. So that box warning is usually not a reason not to try the medicine if it's indicated. It's just something that kids and families need to be aware of, because if it happens, you want to address it, and if you stop the medicine, the side effect will go away.
What is discontinuation syndrome?
So that is basically this medicine's form of withdrawal. So it's not the same kind of withdrawal as if you are withdrawing from like an opiate or, you know, an illicit drug. But if people don't take these medicines consistently, they can experience things like irritability, headache, jitteriness, and it's because the body's reacting to the medicine not being there. Now, eventually it goes away if you restart the medicine or if you stay off of it long enough, and there's no long-term health implications. But where that becomes important is if we're trying to either switch someone over to another medicine or taper them off of one, because you can't just stop these medicines. Otherwise, the risk of getting the withdrawal symptoms goes up a lot. So we'll usually talk about a plan to slowly take somebody off of it or to slowly switch someone over to a new one if we're making a change. Any other questions about the SSRIs?
Yep, the serotonin syndrome.
Okay, so that is extremely rare, but extremely serious. That's why it's up there, because it's important to know the really, really serious ones, even if it's rare. So serotonin syndrome is what happens when the body has too much serotonin available to the brain. And when that happens, the brain and the body, all of their systems basically get dialed up to 15 out of 10.
Oh, okay.
So very high fever, sweating, tremor, nausea, diarrhea, rigid muscles. It's a life-threatening condition. So if that happens, if there's signs of it, the kid has to go to the hospital. And they have to come off the medicine. It is extremely rare, but you have to know it exists, because if it does start happening, you have to act quickly. Knock on wood, I have not had it happen yet for a kid that I've given that medicine to. Any other questions about the SSRIs? Okay. The SNRIs I'm not going to spend a lot of time on because we don't use them as much in kids. In terms of the algorithm, we don't go to an SNRI until you've tried 2 SSRIs first. The side effects are pretty much the exact same thing. The difference is, so SNRI stands for serotonin and norepinephrine reuptake inhibitor. So you're affecting 2 neurotransmitters instead of 1. And the reason we then save that for later is because if more neurotransmitters are getting affected, you're more likely to have side effects, even though the side effects are pretty similar. The next group we're going to talk about are called alpha agonists. And these are primarily used for 3 things. They can be used as a treatment for ADHD, although they're not the first one we use. They can be used to treat tics, and they're used as a major factor in targeting one of the symptoms of trauma, which is the hyperarousal piece and the dissociative symptoms. So now this is what we call an off-label use. So there's not an FDA approval to do this with these medicines, but we've seen evidence that they can help kids who struggle with trauma in terms of like how their bodies respond to those intrusive symptoms and the emotions that they feel from it. It tempers the body's response so they don't feel it as intensely. So for kids in the foster care system, you'll see those medicines a decent amount. You're going to see them more and more as people become more comfortable with that last piece. It's been around quite a while as a treatment for ADHD and tics. So that's been around for quite a bit. Now, stimulants have a very specific use, and this is like Ritalin, Adderall, and this is a particularly confusing class because there's probably over a dozen brand names of it, but there's just 2 generics, basically, and they work about the same. So that is the treatment for ADHD. Hands down, when we go to medicines first, this is what we use first. But As a target symptom, we will try to use them sometimes if a kid displays a lot of impulsive behavior. So with kids with attachment disorders, you see that more with the kids with disinhibited social engagement disorders. They'll just impulsively walk up with anybody. And sometimes the medicines can help with that a bit. We're getting now into medicines that tend to have side effects that are more common and can be more problematic. And a major one with the stimulants is appetite suppression. And I will usually tell families it's not a matter of if, it's a matter of how much while the medicine is in their system. Also, if it's in their system when they try to go to sleep, they won't. So the way we dose the medicine, we try to get it so it's out of their system by the time they go to sleep. And then they will sleep okay. The increased risk of seizures and heart rhythm problems is very rare, and usually that's if there's a family history or the child has a history of those things. And if that's the case, we'll do some screening tests before we start the medicine. The next one are the atypical antipsychotics. Has anybody ever heard of any of these medicines, like Risperdal or Abilify? That sound familiar? Okay. What situations do you see those?
Well, you see it like with depression and things.
Right. Mm-hmm. So they have, Abilify in particular is getting some evidence to be a kind of sidekick medication for depression in adults. But where this comes up with kids a lot is aggression. And there's a reason for that. Two of the medicines that are asterisk, Risperdal and Abilify, are FDA approved to treat irritability and aggression for kids with autism.
Yeah.
It's been generalized to be used oftentimes with kids without autism, even though we don't have the FDA approval for that. Now, these are what I will call more last resort medicines because the side effect profile is more challenging. Kids that take these medicines need regular blood work because the medicine can affect their metabolic systems. Increased appetite and weight gain are common. And some of the rare and serious side effects like tardive dyskinesia is an involuntary movement disorder, usually of the lips or tongue, but it can extend to the rest of the body and that can be permanent. It's pretty rare with these medicines, but it does happen. And gynecomastia is breast development, which can happen in both boys and girls. So that can be particularly unsettling if a boy develops that. So we try not to use these unless we absolutely have to. And then the last group, there's two medicines to this. This isn't exactly a group, but these are medicines used for acute anxiety. And you'll notice what's not on there is Xanax. Have you guys heard of Xanax? Mm-hmm. Yeah. Mm-hmm. So we try not to use the benzodiazepines, which is what Xanax is with kids. A, it doesn't work as well. B, the side effects are problematic. And C, it can be addicting. So these two medicines, Vistaril and Inderal or propranolol, are the ones that we'll go to the most because they're not addicting and the side effect profile is more manageable. Vistaril is similar to Benadryl, so the side effects are similar to Benadryl, and the most common one is it makes kids sleepy. Propranolol is a medicine used to treat high blood pressure in addition to being an anti-anxiety medicine, so the side effects most common to it are low blood pressure, so things like dizziness or lightheadedness. Okay, I know that was a complete and utter whirlwind.